So again, thank you very much for the invitation to join you here, to the course organizers and session moderators. And what I have chosen to do is to start with a discussion of a newly evolving aspect in molecular imaging and nuclear medicine, and that is the ability now to image amyloid deposition in the brain of living patients. And as we're all aware, amyloid is one of the required pathological changes to make the diagnosis of definite Alzheimer's disease on autopsy. And it turns out that we are now able to confirm the presence of pathological amyloid deposition in life with the use of molecular imaging in nuclear medicine. So I'd like to illustrate for you and show you some of the evolution of this approach. So these are disclosures. I don't think any of these are particularly relevant to what we have to discuss today, although some of them do relate to the development and evaluation of amyloid ligands. In the US, there are two approved radiotracers for amyloid imaging. These are Florbetapir and flutamidamol. In Europe, Florbetapir is approved, and I failed to disclose that here. Everything else we may talk about, though, is investigational at the present time. So if we set aside for a moment vascular dementia, which was so nicely articulated for us just now, and focus on neurodegenerative dementias, in virtually all of these, they're characterized by the deposition of pathological proteins in the brain. And there are fundamentally three proteins that may be involved. A-beta peptide generates amyloid, as we refer to it. And A-beta peptide-based amyloid is present in amyloid angiopathy, so a condition that gives rise to spontaneous cerebral hemorrhages. But it is also a required component for the diagnosis of Alzheimer's disease. Tau proteins are characteristically accumulating in a number of neurodegenerations, including progressive supranuclear palsy, cortical basal degeneration, but the dementia syndrome referred to as frontotemporal dementia, which is really frontotemporal dementias, plural. There's a form of tau, though, as paired helical filaments, intraneuronal features that are required together with amyloid to make the diagnosis of Alzheimer's disease. So Alzheimer's is really an amyloidopathy together with tauopathy in the same patient in the same brain. The third protein that we recognize in neurodegenerations is alpha-synuclein. And synucleinopathies include Parkinson's disease and the related multiple systems atrophy. But synucleinopathy with degeneration, just as seen in Parkinson's, is also characteristic of an entity called dementia with Lewy bodies. Many of these patients, but not all of them, also have amyloid deposition. So DLB is a bit of an overlap between Parkinson's and amyloidopathies. And then there are some patients that have all three of these. So they have A-beta amyloid plaques, they have neurofibrillary tangles made up of tau, and they have cortical synuclein depositions. Many pathologists call this the Lewy body variant of Alzheimer's disease. Now, almost 10 years ago, perhaps even a little earlier, was the publication of the first evidence that we could image the deposition of A-beta amyloid in the brain of living humans. This was accomplished at the University of Pittsburgh by Drs. Mathis and Klunk, and this is an illustration from one of their early reports that shows in these color scales the appearance of a normal control individual having been injected with what they then called 6-hydroxy-BTA1, which we now refer to as PIB, Pittsburgh Compound B. So there was a Pittsburgh Compound A, and it was not very successful. But contrast this appearance in a normal individual where the pattern is predominantly reflecting tracer retention in subcortical white matter to the appearance in a patient with probable Alzheimer's disease where the deposition is more intense and now has a gray matter predominant signal pattern. And of even further interest is that some patients with pre-Alzheimer's disease, that is a condition called mild cognitive impairment, some of these individuals look like Alzheimer's patients despite that they're not demented yet. They have an isolated memory deficit most commonly, but they are not demented. These findings by Mathis and Klunk led to a very aggressive search for other agents that might have this same ability in scanning to depict fibrillary amyloid deposition. This slide illustrates some of the chemical similarities. Klunk and Mathis based their tracer PIB on thioflavin T, which is a fluorescent dye used by the pathologist to stain brain sections to make the diagnosis of Alzheimer's disease by binding to amyloid plaques. These four compounds here on the bottom are from pharma attempting to develop analogs that would be labeled with fluorine 18 and would be amenable to regional distribution and potential use for clinical evaluation of suspected Alzheimer's dementia. So flutometamol is basically a fluorinated PIB, so you just put a fluorine here and you get flutometamol. These two on the bottom, Florbetapir and Florbetapir, are structurally only vaguely related to PIB and thioflavin, but all of these molecules have the ability to lie very flat in a three-dimensional space, and the idea, we think, is that they intercalate within hydrophobic domains in amyloid protein when it's present in a beta-pleated sheet cross-linked form. And then this is the newest kid on the block, NAV 469, which is previously an AstraZeneca compound. So all four of these on the bottom are now being evaluated for their clinical ability to distinguish individuals with pathological amyloid from those without. And so here's a single example, for instance, of a patient with flutometamol showing the Alzheimer's disease with cortical predominance of binding on the top. And these are transaxial, here are coronal sections. And this is the appearance of a normal control individual with a white matter predominant signal. Here's the same with Florbetapir. Again, an Alzheimer type patient on the top showing conspicuous cortical accumulation compared to an amyloid negative normal individual on the bottom. And here is an example with AV1. This is Florbetapir, again showing three individuals here that are amyloid positive, including this one who has MCI, compared to this patient who has a frontotemporal dementia. And finally, the AstraZeneca compound, which many individuals think perhaps has slightly better contrast between the normal and pathologic appearances. So here on the top are cortical predominant depositions in an Alzheimer patient versus white matter predominant signal as seen here in this amyloid negative normal individual. So to summarize, these four fluorine 18 labeled compounds, they all share the same biodistribution properties. So you see here pairs of images. The negative or normal distribution for all of these is a white matter predominant signal. And the positive or abnormal pattern is one where the cerebrocortical gray matter has the highest intensity in the patterns. And this is the same regardless of which tracer has been employed. How do we know that these patterns really are associated with pathological amyloid deposition? Three of the four pharma companies involved in evaluating these agents have elected to pursue the same experimental approach, and that is to recruit subjects towards the end of life who are either cognitively normal or who have advanced dementia, and to scan them and then to obtain the brain at autopsy and do histopathologic correlation with the scans. And this slide illustrates what was found for florbetapir. The same is true of flutometamol, and I believe in the European registration also of florbetabine. And that is, these brain scans that are predominantly white matter intensity are associated with virtually no amyloid deposition on pathologic examination, while those scans that show moderate or high cerebrocortical deposition of the tracer are associated either with moderate or very dense amyloid plaque deposition in the pathology. So this is a very tight correlation with high statistical significance and reassures us that the scans are actually depicting pathologic amyloid deposition in life. So the question then arises, if one is going to use one of these tools clinically, how do you distinguish on an individual case basis that the brain is either amyloid positive or amyloid negative? The recommendation so far from the two that are registered in the US is that to classify a scan as positive, you have to have at least one cerebrocortical area with loss of the gray matter white matter distinction. That is where the gray matter is now equal to or even higher than subcortical white matter. And this sort of illustrates how this has come about. So this is pertinent to florbetapir, and it shows the result of the pathologic study that was done. So this is the autopsy group who had pathologically defined a definite Alzheimer's disease, and this is the intensity of cortical deposition prior to death, versus a group of young normal volunteers of, I think, less than 30 years of age. So our assumption is none of these would have pathological amyloid, and none of them volunteered for an autopsy. It's assumed that this is normal range. And then what we have here are clinically defined groups: probable Alzheimer's disease, mild cognitive impairment, and an older group of healthy control subjects. And you can see in each of these, there are many individuals who fall into the pathological amyloid deposition range, but there are a few who also fall below that in the range of normal. And in the case of those groups that are, those individuals who are demented, so for instance these, the prediction is that these people have a dementia other than Alzheimer's disease. Perhaps they have frontotemporal dementia, or at least they have a degeneration that does not involve tau deposition. In the MCI group, notice that there are many who are already amyloid positive, despite that these people are not demented. And something we'll come back to in a few moments, many of the elderly controls, as opposed to the young controls, have amyloid within the range of Alzheimer's disease, despite that they're completely asymptomatic and functioning in a normal fashion. In our laboratory, we have taken things one step further to see if we can assess additional detail of the distribution of amyloid in elderly demented patients and normal controls. And to do this, we've employed similarly acquired MRI, particularly the T1 signal sequence, to identify cerebrocortical locations in the brain, which may be somewhat ambiguous in the amyloid PET scan alone. So we start with a high-resolution T1 MRI, and we then segment this into gray, white, and subcortical, and here you see the cortical gray matter voxels are highlighted in white. What we then do is to strip away everything other than the cerebral cortex, so this is now gray matter defined by the T1 MRI, and we then smooth this to the resolution of our PET scanner. So this is now the way gray matter should look in our PET acquisitions. We then take that smooth gray matter distribution and we register it to this, which is a PIB scan reconstruction. And we, in silico, search this distribution for the peak cortical locations, and then we map them onto the amyloid scan to find the intensity of tracer at those same locations. What this allows us to do is to build surface maps then of the peak amyloid deposition in gray matter. And so here is a subject with Alzheimer's disease. These are all single subject maps. So this is a patient with clinical Alzheimer's. Here's a patient with Parkinson's disease and dementia. Here is a patient with dementia with Lewy bodies who is amyloid positive, and this is an individual with frontotemporal dementia. And what you can see is that the patterns in all of these amyloid positive subjects are really quite similar. They particularly emphasize the frontal lobe in the interhemispheric fissure, the posterior cingulate cortex here, as well as the anterior cingulate cortex. And across these different pathological classifications, this pattern appears quite consistent. In fact, if we take 28 subjects with probable Alzheimer's disease and average them together, this is the pattern of their PIB binding. Dementia with Lewy bodies similarly show characteristically a very similar distribution, whereas frontotemporal dementia patients do not show significant cortical amyloid accumulation at all. Now you ask, how characteristic is this pattern in Alzheimer's and related dementias? To address that, this is that average of 28 individuals again depicted for you. But in this row, rather than average signal intensity, what we've shown now is the prevalence of cortical values that show a significant, that is higher than 1.6 times background, amyloid signal. And so the more intense these voxels are, the higher the percentage of patients have an abnormality in this area. And you can see that these patterns look very similar one to another, which tells us that each individual Alzheimer patient has a very similar distribution of amyloid deposition. And again, the areas that are represented are frontal lobes, the posterior cingulate precuneus, the anterior cingulate, and areas that are conspicuously spared, the occipital cortex and the pre- and post-central primary somatosensory and motor cortical areas. This distribution is very similar to what's been found pathologically in terms of the distribution of amyloid in patients with Alzheimer's disease. So, the regions most likely to be involved I've just reviewed, and they're listed for you here. Relative sparing of pre- and post-central cortex and occipital cortex. And I didn't point out to you, but the cerebellar hemispheric cortex is virtually never involved, and many of our analytical strategies involve comparison of cerebral cortex against the cerebellum as a point of reference. So here is a representative scan with one of the fluorine-18 labeled agents. This is the scan on top. This is the patient's co-registered MRI, and here's the fusion image. You can see how the MRI is very helpful because this signal here is not in the cerebral cortex. This is actually in a thickened area of marrow in the frontal bone. So it's not a positive scan. This is a normal or negative amyloid scan. Notice here in the coronal image, this is the cerebellar cortex, which has a very similar signal intensity to this patient's cerebrocortical gray matter. And this is a typical amyloid positive example where now the frontal cortex is conspicuously involved, the posterior cingulate as well. You can see coronally there's the cerebellar cortex, and all of this cerebral cortex exceeds the normal threshold. You'd wonder about this area. Is this an area where the cortex is spared? But you can see with the co-registered MR, there's actually localized atrophy in this area, so it's not actually cortex that's spared, it's missing brain. Now, a very important caveat about amyloid imaging in terms of its significance and how we should interpret it. This, I believe, was first reported by the group from Washington, St. Louis, Mark Minton and his colleagues, where they again showed us that in patients with typical Alzheimer's disease, you see this cerebrocortical pattern of amyloid accumulation compared to the cerebellar cortex. In cognitively normal elderly individuals, and here they were 65 to 80 years of age, most often one sees this subcortical white matter pattern, which is interpreted as negative. This is a normal pattern. But in about 1 out of 5, 20% of cognitively normal elderly individuals, the pattern resembles that of Alzheimer's disease, where the predominant signal is in cerebral cortex, not in the white matter. And the older patients are amongst the recruited normal subjects, the more prevalent this pattern is. So at age 40 to 50, it might be only 10%. At age 70 or thereabouts, it's about 20%. And older than age 80, it can be in excess of 1/3 of normal individuals have this appearance. So that's anomaly number one. You can be amyloid positive just like AD, but be cognitively normal. The second observation is one that's been made by several. This is a case from our laboratory where we scanned a patient who had mild cognitive impairment, and she had this appearance of pathological amyloid deposition that looks just like Alzheimer's disease. We followed her for 2 years, and she returned to our lab 2 years later and had another scan. And this time, she has also got an abnormal pathologic amyloid deposition pattern, but notice that there's virtually no change over these 2 years. It looks just as bad originally as it does 2 years later, but now she's demented. So she's had a loss of neurologic function that allows us to make a diagnosis of Alzheimer's disease, but the amyloid was there when she only had forgetfulness, and it didn't change while her abilities declined substantially. So there's no correlation in this one individual, but in also case series, between the intensity and the progression over time of amyloid deposition with PET and the development of cognitive impairment and dementia. To be honest, we should have expected this because more than 10 years ago, these kinds of data were reported in the literature by more than one group, but this is a very nice one, where there's an autopsy evaluation of both neurofibrillary tangles, that is the tau pathology in Alzheimer's disease, as well as the amyloid plaque deposition. And so what you see here on these graphs are the relationship between how much neurofibrillary pathology is present versus the patient's mini-mental state examination prior to death. And you can see that those that have very high functioning here with MMSE in the range of normal have virtually no neurofibrillary tangle pathology. Whereas if one looks at the amyloid pathology, even people with cognition in the normal range can have very high amyloid deposition, and there's virtually no correlation of any significance between the intensity of amyloid deposition and cognitive functioning. So it appears that the neurofibrillary degenerative pathology in Alzheimer's disease is relevant to neurologic function and to cognition, whereas the amyloid is a required element for the pathologist, but its intensity does not directly correlate with function. This has now been explained further in a very elegant and brilliant, I think, experimental design, where investigators went to South America, in Colombia, and found a very large family who suffer from an autosomal dominant form of Alzheimer's disease. They have a mutation in the gene for presenilin 1, and this mutation results in a very highly predictable onset of cognitive abnormality followed by dementia. So that at around, I think it's age 43, family members who have this mutation all develop mild cognitive impairment. They become forgetful. By about age 49, 48 or 49, they all become demented. And in this family with this single gene mutation, the timing of these abnormalities is very consistent. So what investigators did is took family members to Arizona in the United States and did amyloid scanning. And these are reconstructions of the amyloid appearance in subjects from this family as a function of age, although it was done cross-sectionally. But notice that here is the age of onset of memory failure, mild cognitive impairment, and here is the onset of dementia. Notice that the amyloid positivity develops about 15 years before the first symptoms, and probably close to 20 years before the development of dementia. So at least in this monogenetic explanation, the amyloid deposition that leads, we think, to neurodegeneration and dementia comes many years in advance and is asymptomatic at the time it becomes nearly maximal. So this leads then to the speculation that in Alzheimer's disease, there's a period where amyloid deposition occurs, but is asymptomatic. After some time, the amyloid appears to then trigger other neurodegenerative aspects, including losses of neurons and synapses, the presence of neurofibrillary tangles, and at some point, enough pathology of neurons that a clinical diagnosis can be made. And unfortunately, in our current system, it's at this point, or maybe afterwards, that we initiate attempts at symptomatic and more recently interventional therapies. But the point from this slide is that we would predict that this would be a very inefficient time to intervene if the pathology that we're targeting, say with amyloid deposition and amyloid burden, is way back here. So, the caveats of amyloid as we understand them or believe them now, first of all, remember that amyloid positive in a patient scan does not mean they have Alzheimer's disease. We know that amyloid is required for the diagnosis of AD, but it can also be present in dementia with Lewy bodies and perhaps other minor dementias that also are associated with amyloid. Remember also that non-demented elderly subjects can be amyloid positive, and many of us believe that this means they're on the pathway to developing Alzheimer's disease, but we need to follow these amyloid positive normal individuals to see whether that's correct or whether it's possible that some of us can have amyloid in the brain and tolerate it without the development of dementia years later. So this is possible. Some of us believe it may turn out to be true, but it has not yet been shown. So in conclusion, it appears that there are now 3 or 4 18F labeled amyloid imaging agents that show very early and very convincing evidence of success in depicting pathological amyloid deposition in the brain. The proposed clinical use, and you'll find that there are recommended guidelines in the Journal of Nuclear Medicine from the Society of Nuclear Medicine Molecular Imaging. The proposed use is not for the diagnosis of Alzheimer's disease, but instead perhaps to identify demented patients who do not have the Alzheimer's pathology and instead would have frontotemporal dementia or one of the non-amyloid related pathological degenerations. Finally, we think that amyloid imaging will become crucial, though, when and if we have a therapeutic intervention that works against the deposition of amyloid. Because in this case, we now believe you will have to scan patients well before the onset of memory failure and other cognitive deterioration, and you would need to know which of these elderly individuals have amyloid and thus have the target of your therapy. So as pharmaceutical industry becomes more advanced in possible treatments for Alzheimer dementia, the significance and role of amyloid imaging, I think, will become critical to first the development of treatment and to its application. So I'll stop here and then move directly to the next talk. Is that what you would like?